Good afternoon. My name is Candice Leferber, and I work with a team on Project Watch, also known as the Birth Score program, and it's housed in the Department of Pediatrics through a grant supported by the Department of Health and the Office of Maternal, Child, and Family Health. Today, we're going to, I'm sorry, Kelly. Kelly's helping me with my slides today, so I have to remember to say next. Our learning objectives today are kind of in two parts, but we're going to have three speakers. So the first one is we are going to share how Project Watch collects viral hepatitis data, surveillance data from birth hospitals, and the reporting for that. And then the following two speakers are going to quantify the burden of Hep C infection among pregnant women and babies in West Virginia using all of our statewide surveillance data and talk about the reporting requirements at the state level as well. Next, please. So just a little snippet of history about Project Watch, which was called the Birth Score program for many years. Back in 1989, this tool was implemented in West Virginia to try and reduce the postneonatal mortality rate that was extremely high in West Virginia. It was a scoring system that allowed providers to identify the most at-risk infants who may be at risk for death in the first year of life. Then in 1998, coupled with that birth score was the newborn hearing screening, universal newborn hearing screening for all babies born in West Virginia. And those two initiatives were implemented in the form of a state mandate for West Virginia birth hospitals. So the primary objectives of Project Watch have evolved somewhat over time, but initially, and really with the scoring tool, we want to identify those babies who are at the greatest risk of poor health outcomes that can be preventable, can prevent death from happening in that first year of their life when they're very vulnerable. We also want to link them with pediatric providers, case management to initiate closer follow-up. Next slide. So Project Watch is a statewide newborn risk surveillance program that provides many opportunities for important referrals and having a pulse on what's going on with infant and birth outcomes. We collect data related to mom's substance use during pregnancy, so what infants are exposed to, and those who do have neonatal abstinence syndrome at birth, hepatitis C exposure, which we're going to talk in depth about today, and other maternal and infant factors like gestational diabetes, for example. Our system allows hospitals and providers who are identified by parents and families to submit data right after birth, usually upon discharge, and we have a real-time surveillance capacity across the state, making referrals timely as well. Next slide. I know you can't see this, but these are all the variables that are collected on our surveillance tool. It used to be a paper form when I started about 17 years ago. It's transitioned into an electronic system for some hospitals, and other hospitals within the WVMedis umbrella and Cabell and Cerner as well have built the birth score surveillance data within the medical record. So we get that data directly from the EMR. If you go to the wvdhhr.org/birth score, you can look at a copy of all of the variables included on the form. There's a PDF there. Next slide. So why did we start calling it Project Watch? It was the birth score program, and that is actually how it's stated in the state legislation, but it really has come a long way and transitioned into something much more larger beyond just that score, identifying the at-risk infants. Newborn hearing, as I said before, in 2012, we added the universal critical congenital heart disease screening to the tool. And then in 2016, intrauterine substance exposure and NAS, and 2020, maternal hepatitis C. So we started beginning to take a closer look at those infants who were exposed. Most recently, we've added vaping because we are seeing a decline in smoking and tobacco use, but an increase in vaping. So a lot of our providers that serve on a medical advisory board provide guidance with our state partners about what we want to begin taking a closer look at, and vaping has really become another area of focus. Next slide. So why did we, why is maternal Hep C infection important for Project Watch to capture with surveillance? Maternal Hep C infection often has no symptoms during pregnancy, but infants exposed remain at risk. And so tracking exposure data is important. It helps us understand the burden of disease in our state, identify trends over time and geographic trends. And we really want to increase early identification of exposed infants and assist with coordinating birth hospitals and pediatric providers and public health systems. Ideally, when this works well, surveillance data informs policy and prevention and helps to allocate resources where they're needed most. And we know this is really important in West Virginia, where maternal Hep C rates are disproportionately high. Next slide. The timing of adding maternal Hep C wasn't ideal. We rely on our partners at the state to create policy for us to share with birth hospitals regarding the state mandate when we make changes. And it got implemented right before the COVID pandemic hit and everything shut down. So I don't expect you to read all of this, but this is the policy that was effective January 1st of 2020 to establish a consistent policy to facilitate medical follow-up for infants born in West Virginia having signs of NAS and exposure to Hep C. So not only did we add those items to the surveillance data, but we also then began making notifications to the providers that families indicate they're taking infant to for follow-up care. That data isn't perfect, especially for those in foster care, but it's definitely better than no notifications at all. Next slide. This is just another summary slide of the policy. Next slide. So in 2020, if you were at a hospital and you were a bedside nurse and you were completing the required birth score data for an infant, maternal Hep C, that item highlighted, was all that you saw there. Yes, no, and unknown were the options for our data collection starting in 2020. Next slide. Right after we started collecting this data, the National American Academy of Pediatrics updated their recommendations to earlier testing of those infants exposed to Hep C. The updated guidance recommends that testing begin as early as 2 to 6 months for perinatally exposed infants. And that was a large shift from the recommendations previously that delayed testing until 18 months of age. I think AAP did a good job of helping providers understand that getting infants in for testing earlier reduces the loss to follow-up. We can identify the infections sooner, and linking them to specialty care with Peds ID and others is important to do earlier on, giving families more guidance and support as soon as possible. Next slide. So we've expanded our surveillance data, and Dr. Umer is going to talk about that following me. But now Project Watch does include the hepatitis C antibody and HCV PCR RNA test results. And in the larger picture, from a public health surveillance, we want to improve follow-up screening outcomes for infants exposed. So we want to have another layer of data that's really important clinically. Next slide. The next few slides are just showing a visual for our birth hospitals, specifically of the new data elements that have been added. So the maternal hepatitis C is still there, yes, but you can see now that you have options under the HCV antibody, which is required to be answered for every infant. Test not performed or results pending or other is also available if the result isn't there in the chart. Next slide. And this is just demonstrating the PCR. And the next slide shows you the viral load that we are also collecting. Next slide. So really, we wanted to take, this opportunity to talk about why Project Watch is really supporting early identification. It's real-time tracking right after birth. The communication with our pediatric providers in primary care settings is a piece of the data system with the state mandate notifying providers. So it's alerting those providers about exposure status, and the surveillance monitoring through the state health department is another layer of very important requirements that providers need to be aware of, and really working together to identify gaps that happen in follow-up care with those infants is one of our main goals. We do want to use our statewide data to improve systems and outcomes, and this moves the surveillance beyond just counting cases and really into a good public health intervention. This is an AI-generated infographic that I thought did a great job on really giving you a nice visual from pregnant moms with hepatitis C delivering in our birth hospitals. Those are who we're collecting surveillance data on, and real-time data entry or tracking for Hep C, making really timely and important provider notifications who hopefully are seeing these infants and having screening much earlier, between 2 and 6 months of age, and improving follow-up care and linking them to specialists to get treatment if necessary. So I will go ahead and transition Kelly to Dr. Umer, and I'll take any questions about Project Watch either now or later on. If you have anything in the chat, I'll keep an eye on it.
Thank you, Candice. Good afternoon, everyone. My name is Amna Umer. I am an associate professor in the Department of Pediatrics at West Virginia University. And I'm an epidemiologist by training. I worked with the Project Watch team for almost 10 years, or maybe even more than 10 years right now. And my area of research is looking at substance use in pregnancy, and as substance use and maternal Hep C are very intertwined. I'm also researching on maternal Hep C, especially looking at data from Project Watch that looks at the entire state of West Virginia. So today I will provide an overview of maternal Hep C in West Virginia using Project Watch data. For all the numbers that I'll be citing today are coming from this surveillance tool, the Project Watch that Candice just went over, and also explaining its trends over time, the substance use association, the geographical patterns, the sociodemographic patterns associated with maternal Hep C in the state. But before I start going into the numbers, it's really important to understand how maternal Hep C testing is done. And when you are reading an article, whether you are looking at the antibody testing result or you're looking at the PCR results. So I'll quickly explain this. So ACOG recommends universal Hep C screening during each pregnancy. The screening starts by testing for HCV antibody. And if these antibodies are non-reactive, no further action is needed. But let's say the antibody tests positive, it is reactive, it goes on to a reflex test, which is your PCR testing. And if the antibody is reactive, but the RNA is not detective, it really means that the mom had the infection some point in time, but not necessarily she does not have active infection right now. So her infection was cleared, or there was a false positive antibody result. The second is, if the antibody was reactive and the RNA was detective, it means there's current active infection during this pregnancy. So it's very important to distinguish, as most studies, even our own study, that when we are presenting Hep C prevalence or rates, we are presenting data on Hep C antibodies, not necessarily on those with current active infection during pregnancy. So distinguishing this is really important. And so many of the national studies that I will be comparing Project Watch data with today also have this limitation. They are looking at the Hep C antibody results, which would again tend to overestimate the prevalence in the state or nationally. So the reason for this is that when Project Watch started collecting data on maternal Hep C, it was just collecting data, and it had three options: yes, no, or missing data, and it did not differentiate between that past and current Hep C infection. And we understand this limitation, but it's always not very easy to add new fields and collect data because you need a lot of training but for each hospital. So moving forward, we have actually started collecting maternal Hep C data on antibody test results, the PCR results, and the viral load starting right now. So it just started like a month or so ago in 2026. But all the data that I'll be presenting today is using 2020 to 2025 data where we did not have data on the PCR necessarily. So we cannot differentiate between past or current Hep C cases in the state. So this is using Project Watch data from 2020 to 2025. So as I mentioned before, Project Watch collects data as no, unknown, or missing, and those with Hep C. So from 2020 to 2025, we are seeing a decrease in maternal Hep C over time. So from 3.5% to almost 1.6% in 2025. And we are seeing a gradual decrease over time. Also, it's important to note that when Project Watch started collecting data, there were a lot of missing or unknown cases, so around 40% in 2020. But each year, if you see, the missing cases are decreasing over time and our data is improving overall. When you are presenting the rates or the prevalence for these overall 6 years, the rate is 2.5% or 25 per thousand deliveries. But those include the unknown categories in your no categories. But when you exclude the unknown or the missing values, your denominator changes and the rate increases overall. So when you exclude that, the rate in West Virginia is even higher. It is 32 per thousand or 3.2% for these 6 years of data. We have published this study. It was published last year in the Journal of Addictive Disease, and we have clearly mentioned it to the readers that Project Watch, there's a limitation. Project Watch does not capture the type of Hep C testing that was performed. So this is a limitation of the data that we have presented so far. This is looking at maternal Hep C rates by month. And you do see that there's some fluctuation in Hep C rates by month. But overall, if you see that the trend, you'll see that the maternal Hep C rates are decreasing over time. So this slide, we are comparing. On the right side, we have Project Watch data. And on the left side, we have data that was collected by the West Virginia Vital Statistics System. And we have 3 overlapping years from 2020 to 2022. And this comparison that I just want to make today is just to share that we feel very confident in the data that Project Watch has been gathering on maternal Hep C. Our rates are very similar to what was presented and what was collected by the Vital Statistics System as well. So this figure here, I wanted to compare the national rates of maternal Hep C to our rates in West Virginia using Project Watch data. So from 2016 to 2021, This is the latest national data that we have. This is the citation for the study as well, which was published in the National Vital Statistics Report. And we do not have data beyond 2021 for any national estimates for maternal Hep C. So if you look at the national data, you'll see this is per thousand. You do see a slight increase in maternal Hep C cases from 2016 to 2020, and then a slight decrease from 2020 to 2021. But there are two overlapping years, the 2020 and the 2021 year, where we have data from our state as well, from Project Watch, and to compare it to the national data. So if you see for those 2 years, for example, just looking at 2020, we see that the rate of maternal Hep C is 5 per thousand nationally, and it is 34 per thousand nationally, of 34 per thousand for the state of West Virginia. So it's almost 6 times higher. There's definitely a disproportionate burden of maternal Hep C cases in West Virginia. And also to mention that this data, the national data, in this published work, had the same limitation as we have using Project Watch data. They also do not differentiate between past and current or active infection. So our data is very similar in that respect, and that's why we can actually make this comparison of what we are stating right now in this figure. So this is that our published work, which I provided the citation in an earlier slide. Here we were looking at data from 2020 to 2024 and looking at the sociodemographic characteristics of Hep C, of maternal Hep C. So we see that in the overall population, maternal Hep C was 3.8% or 38 per thousand. But in certain age groups 30 and 34, the prevalence is higher. And then in age group 35 to less than 40, the prevalence is almost double in that age group. The prevalence is also 3 times higher. The prevalence is almost 10% in those with less than high school education. It is almost double for those women who have Medicaid health insurance. We do see very slight variation by the rural-urban classification in West Virginia. But when we look at maternal prenatal care visits, so those women who had less than 10 prenatal care visits have really high rates of maternal Hep C. So if it is 3.8% in the overall population, it is almost 14% in those with inadequate prenatal care. So this is now looking at the association between substance use and maternal Hep C. So we do see a strong association between substance use and maternal Hep C. Almost 1 in 5 pregnant women with substance use have Hep C as well. Now moving on, if you look at the opioids, those using opioids, nearly 1 in 2 have Hep C. Stimulant use is really high. It's like 40%, the prevalence for those who are using stimulants. Gabapentin, yes, we do see really high rates of maternal Hep C in those using gabapentin, but this is really, we just did another study where we do see that a lot of, around 60% of those women using gabapentin are also using opioids. So that could be the reason why we are seeing such high rates of maternal Hep C in this population as well. This is another way of looking at the data where now we are looking at among those with maternal Hep C, what are the rates of substance use? So among women with Hep C, substance use prevalence is more than 66%. And more than 70% reported smoking during pregnancy, and nearly half reported using opioids. 1 in 5 reported using stimulants. That's your 20% over there. So these findings, really emphasize the close relationship between the substance use epidemic and the Hep C infection rates. So this slide compares the temporal trends of maternal Hep C and maternal opioid use over time. And both patterns, if you see on the top is your opioid use and in red is your maternal Hep C, that both patterns, they appear to move together over time. And really this suggests the overlapping epidemic. And overall, we are seeing a decrease in opioid use over time. And, concurrently, we are seeing a decrease in maternal Hep C over time. And this might be the reason why we are seeing a decrease in maternal Hep C as the opioid prevalence is also decreasing over time. This figure is comparing just the temporal trend of Hep C and the stimulant use over time. And here we do see some overlapping trends here as well, suggesting that there is a relationship between stimulant use and Hep C as well. This is a study that we did, and it was published in 2024. There's the citation for this study. We were looking at just those women who are enrolled in Drug-Free Moms and Baby, which is a statewide substance use disorder program. And these women, for this study, these women were enrolled between 2018 and 2022. And we saw that the prevalence of Hep C in this substance use population was 23%. So similar to what we saw in Project Watch as well. But it's also what I really wanted to highlight here that there's a lot of polysubstance use, and the rates of maternal Hep C are really, really high in that population with polysubstance use. So for example, this table here, I'm showing the rates of maternal Hep C in those who were using stimulants alone, and that was 23.7%. So 237 cases per 1,000 deliveries. But those with opioid alone, it was 37.3%. But now, looking at that group where the women were using both opioids and stimulants, the rates of maternal Hep C was close to 60%. So that's a huge number. This is like 600 cases per 1,000 deliveries. So, it's really, really, I just want to make a point that Hep C and substance use, when you're looking at interventions, you have to focus on both of those aspects of mental health, substance use, and infectious disease when you want to deal with this crisis. We also examined the geographical patterns by county level data in West Virginia. And the counties that are highlighted in this figure are those counties that had higher than the state average of 3.8% or 38 per thousand births. So you do see a lot of those high states with high prevalence are those in your southern part of West Virginia, your northern panhandle, and your eastern panhandle. They have one of the highest rates of maternal Hep C. This is another way of looking at the data where we're trying to see where the most burden of Hep C is, where are they most concentrated in the state. So around, sorry about that. So around 8 counties in West Virginia contribute to 50% of all Hep C cases in the state. And if you look at 2 counties, the Kanawha County and the Cowbill County, they account for 30% of all Hep C cases in the state. So what does this data really tells us? For maternal Hep C cases overall, the rate is 2.5%, which means 1 in 40 women have Hep C, compared to national data of 0.5%, where 1 in 200 women have Hep C. So there is almost 5 times higher rates in West Virginia compared to the national numbers. And again, we know recent data tells us that almost half of new Hep C cases in the US are associated with injection drug use. And one of the reasons why we do see such high rates of Hep C in this population is because if you look at the opioid rate and the stimulant rate in the state, they are almost 10 times higher than the national rates. And this is really telling us, the overlapping epidemic and highlighting the need for integrated maternal health, mental health, substance use, and infection disease strategies that are needed to combat this epidemic, this joint epidemic. We would like to acknowledge all our partners that have helped make Project Watch, the surveillance system so efficient, and they've been giving us, guidance on, what to collect, what not to collect, and constantly, helping us improve the data. Thank you so much. This is all I had, and Kady Pack will be discussing the perinatal Hep C reporting in West Virginia. Thank you so much.
Hi, everyone. I'll be presenting. Please let me know if you can see my slides.
We can see them.
Great. Thank you. And I'm sorry, I have lost the use of my camera in the interim, and I'll try to resolve that at the end of the presentation. So good afternoon. My name is Kady Pack. I am the Viral Hepatitis Surveillance Coordinator and Epidemiologist for the West Virginia Department of Health, Bureau for Public Health, Office of Epidemiology and Prevention Services. So this final portion of the session will focus on perinatal hepatitis C disease reporting requirements from a provider perspective. We will review the legislative rule, reporting timeframes, as well as each section of the case report form. I'll emphasize the purpose and use of the data that you provide and share how it directly impacts the work that we do here at the State Health Department. Perinatal hepatitis C became a nationally notifiable condition in 2018, and West Virginia included it as a reportable condition starting in 2022. This graph shows the case counts for perinatal hepatitis C detected in West Virginia from the time of that surveillance initiation in 2022 through 2025. These numbers include cases that met and did not meet case classification criteria to be considered a confirmed or probable case based on our adopted CSTE surveillance case classification. West Virginia does not currently mandate negative hepatitis reporting. So from a surveillance perspective, it's difficult to know if all infants who are perinatally exposed to hepatitis C have been identified, tested, and adequately treated for hepatitis C infection. As of 2022, nearly all of those cases represented in the graph were identified through positive public health laboratory reporting. And considering what we know about the rate of hepatitis C, specifically in West Virginia and among people of childbearing age, we would have anticipated some higher numbers for these perinatal infections in cases that we've identified. So as I mentioned in the previous slide, perinatal hepatitis C became reportable in West Virginia in 2022 when it was added to the Legislative Rule 64 CSR 7. This is often referred to as the reportable disease rule, and it mandates that healthcare providers, facilities, and laboratories report communicable diseases to the West Virginia Department of Health, Bureau for Public Health. Hepatitis C falls under Category 5. Acute and perinatal infections are reportable to the health department within 1 week of notification, and these reports should include hepatitis A and B serologies, as well as transaminase and bilirubin levels. It's important to note here, when laboratories send a test result, that does not fulfill the provider responsibility for sending case report forms to the State Department of Health. If you identify an acute or perinatal infection of hepatitis C, it should be reported within 1 week to our state health department. So this chart is an oversimplification or a helpful visualization tool, and it shows each reportable communicable disease within different categories by receiving entity and the time to report. And as you can see, for category 5, the information is referenced under the blue heading in the last column. This chart is available online, and we do have printed laminated copies available through requests to the Office of Epidemiology and Prevention Services. And down below, it's probably not legible, but you can, there's a fax number to be used whenever you need to fax those case report forms to our office. So providers should utilize the case report form that I've referenced. For each identified perinatal hepatitis C infection, we will use the remainder of the presentation to go through this document, the components within, how it's used, and the method for reporting. And I've included the link to the website where this form can be accessed. Currently, our office website is under major construction, so this link may look different, and it may be subject to change. So as that is updated, I'll be sure to share that. Be sure to share that with the host for Project Echo. So the first section of the case report form includes demographic information for the case patient. This allows the viral hepatitis program to identify disease trends, provide policy recommendations, and guidance for the public health, the public as well as health professionals. The completion of this section ensures that surveillance staff here at the West Virginia Department of Health have the most up-to-date contact information for the case patient. And as many of you are aware, oftentimes these cases tend to experience higher instances of changes in custody or guardianship from the time of birth through early childhood. So having as current and timely information is really helpful for this section. It allows us to determine the appropriate guardian to connect with, to provide and offer additional services, to review test results, and provide disease education for transmission and prevention. The next section includes the investigation summary, which we can fill out here at the state. So that top box may not be applicable as a reporter, but the two lower sections are really important. The reporting source and healthcare provider fields allow us to identify the reporting entity and maybe a specific contact person, and allows us to have continued communication should that be necessary to gather additional details on the case patient or clarify any questions that we may have as we are reviewing the record. The clinical findings are also very supportive and help provide evidence of symptomology and onset date for symptoms so that we can evaluate and classify that case and determine an exposure window. And it allows us to really evaluate transmission mechanisms. So though the laboratory test results are reported separately to the West Virginia Department of Health, this section of the form really supports a holistic review of the case patient and includes tests that we may not otherwise receive if they are negative. So it does help fill in the gaps as we are assessing these cases for reporting purposes. And it also allows us to evaluate their infection status for the condition being reported. It helps us review the accuracy of data that we've received via other methods. The testing methods that have been employed, are they age appropriate? Are they reliable? Do they fit classification standards that we have, and allow us to ascertain case status for data reporting to the CDC, as well as many of the annual reports and quarterly reports that we provide for the public and our partners. And just to call out to that comments box at the bottom, we do have staff internally manually review those to ensure criteria is met, or if you have any additional information that you would like for us to consider as we review the form and enter that data into the system, that's a really great option to be able to give a little bit of a bigger picture for the case that you are reporting. So this section of the form includes information requested for the birth parent, their name, demographic information, and health status at the time of report, if it is known. It allows staff to review maternal infection history within our public health disease surveillance system and evaluate the likelihood of vertical transmission. During this review, we often identify other children from prior pregnancies with hepatitis C exposure due to the review of the birth mother's disease history. And the lower section supports identification of possible co-infection and the need for additional follow-up, custodial rights to the child, and other opportunities for linkage to care efforts. So as we know, hepatitis B and C do have some common risk factors, and we may expect to see co-infections among people of childbearing age engaging in these risk behaviors. So this section fills another gap that we may see if perhaps the child had a hepatitis B exposure and they have had hepatitis B immune globulin administered at time of delivery or shortly thereafter, as well as the hepatitis B vaccine. Our viral hepatitis program supports the perinatal hepatitis B prevention coordinator position, and this position supports the local health department in turn in the identification and follow-up of all hepatitis B positive pregnant women. And they collaborate directly with birthing facilities to ensure that exposed infants receive the appropriate PEP and follow-up care at birth through to the completion of post-vaccination serologic testing. We also include some information on this form for the reporter to provide any additional details about other exposure pathways by means of infection. And these last two sections of the form really indicate to our internal staff that are reviewing these if any additional action and steps need to be taken to address possible outbreak scenarios or perhaps disease education gaps and linkage to care efforts that we can support. Some elements of the sections may not be applicable to all providers and reporters, but if the information is known or suspected, it is really helpful to include that. It prompts the provider to indicate if the patient and or their guardian was educated on the infection status of the case patient and given prevention information to eliminate further transmission and disease spread. If you are aware of any linkage to care efforts or treatment efforts that have been made on behalf of this patient, it's helpful to include that. It supports our resource allocation here at the state. We are fairly limited in staff capacity, so any additional information we can gather to understand where we can best apply our support and be most efficient in that application is helpful from our perspective for sure. So once the form is complete or as complete as possible, if you could please fax it to our office at the number shown there below. And finally, I thought that this would be a helpful slide to sort of illustrate the collaborative nature of the perinatal hepatitis C disease detection as far as testing, diagnosis, prevention, and elimination. It describes some of the key roles of the organizations that support these efforts and the ways in which we interact to try and improve the health outcomes for people living in our state. So just to highlight and summarize at the end of the presentation, the impact of perinatal hepatitis C identification and reporting cannot be understated. Not only does it support compliance with the legislative rule, but it increases our understanding of the disease burden of perinatal hepatitis C, thereby raising awareness of an emerging infectious disease and the impact that it has on our population. It fosters relationships among partner organizations to collaborate and increase our effectiveness and reach. Data drive evidence-based interventions and help us track progress toward our goal of hepatitis C elimination. And most importantly, like I mentioned, it really does support the improved health outcomes for those impacted by perinatal hepatitis C. So we value the work that you do and really appreciate the collaboration that we've been able to have with our partners. And I'm happy to answer any questions and have included my contact information and would welcome any discussion about perinatal hepatitis C.